Good evening, doctors. Thank you for being with us this evening. With significant changes in lifestyle, India has the highest burden of acute coronary syndromes in the world and the greatest single cause of mortality and rising incidences of coronary artery diseases in the young is particularly a cause of concern, with anticoagulation being one of the prominent parts of therapy. Today's panel will devote their expert opinion on anticoagulation in acute coronary syndrome. The Times of India brings this event to you in association with Critical Care Division of Biological E Limited, one of the esteemed anticoagulant producers in India. I'd like to welcome my esteemed panel of doctors who've taken their time to be with us today. Dr. Praveen Kahale is an interventional cardiologist and heart failure and transplant cardiologist. Sir, welcome to this webinar. Dr. Bhaskar Shah is an interventional cardiologist at Ashirwad Heart Hospital and Jupiter Hospital. Sir, welcome to this. Dr. Dayanand K. Kumla is a senior interventional cardiologist at Jupiter Hospital and Jai Anand Hospital. Sir, a very warm welcome to you too. So as we begin with our questions, we'd like to address Dr. Dayanand with the first question. Sir, what are the challenges in management of various ischemic heart diseases in India? How ACS is significant amongst them? Sir, your viewpoint and opinion.
At the outset, let me thank Biological and Times of India for having called us here to speak on the coronary artery disease. Now, as far as India is concerned, you know, the ischemic heart disease burden is going on increasing. And if you see acute coronary syndrome, acute myocardial infarction or unstable angina is a major chunk in the disease pattern which we nowadays treat. About 80% of cardiovascular diseases are because of the related to heart and cerebrovascular stroke. Now in India, the population is widespread, from lower socioeconomic state to higher socioeconomic state and very high affluent people. In lower socioeconomic state, you may find the incidence of coronary artery disease on the rise. Maybe their food intake cannot be proper, not eating proper vegetables, lot of fruits. If you are devoid of these things, maybe you get into these problems. Tobacco is another bad habit that most of them have, and that is also a killer in as far as coronary artery disease goes. Now, even taking proper medications in the lower economic strata, maybe people many times find it difficult to fund for their medications. So optimal therapy is not being meted to them. You say one particular drug and you advise them particular dosages for n number of years or n number of days. But many times these people may skip one or two tablets because of paucity of money. So this is another major problem in India. Now, as far as the lack of awareness for healthcare facilities, not all of them have got those medical facilities and they can afford to go to all these major hospitals. There are certain people who land up with entering these small public health offices or hospitals. And a large number of people who stay in the villages, it is very difficult for them to even get a simple ECG done. Many times I hear from my patients, they have to go miles and miles away to get an ECG done. Whereas in the city, you find every building or every next door neighbor, there may be one doctor. And ECG is so many ECG centers are and doctors are freely available. So to be able to get them is also many times difficult. So poor people many times find it difficult to go to these places. So that is why the burden is going on increasing. In one of the studies, it was found that the urban and rural population, definitely the urban population, the incidence of coronary artery disease is definitely more. Now the stress factor is the major thing. Now last 1.5 years, we have been locked down with the corona epidemic and pandemic which is going on. That has caused a lot of problems. People stay at home and are stressed out. Working from home is a major stress. So in coronary artery disease, I would say the first factor is stress. Then you have other things which will end up with the coronary arteries. Okay, thank you.
So just a small aside. So we do say that the lifestyle, sedate life, and like the urban habits are a major cause of concern as we move today.
Yeah.
Fair enough, sir. Thank you very much. The second question, Dr. Dayanand, again to you, sir, is that what are the likelihood signs and symptoms indicating an ACS secondary to coronary artery disease, sir?
Sudden onset of chest pain, which patients experience, all of a sudden, it's like a bolt from the blue. Suddenly he gets a chest pain and he has profuse sweating. That is the sign of acute heart attack. So he rushes to the hospital, gets an ECG done, and it is diagnosed. Many a times people do experience chest discomfort after meals. That is called as postprandial angina. There are many people who suffer from postprandial angina. It's a common notion for most of the lay people that if anything happens after meals, it has to be acidity and gas level. So that misleads them. There are people who end up taking lots of hygiene and all at home, and then they finally, when they come to a doctor, there's already a massive heart attack, and it becomes very difficult to treat such patients. So that is one of the things. Second thing, that patients may have symptoms only on walking. On walking, they get chest pain. They sit, they take some rest, then he is fine. And these guys, when they go to the hospital, when they are at rest, the ECG may be normal. It's the doctor who examines and takes a proper history, which can only come to a clue that this particular gentleman is suffering from ischemic heart disease or underlying heart disease. There are certain people who just get left arm pain, right arm pain, jaw pain, neck pain, and these are also radiating symptoms, radiating signs which we see in patients having coronary artery. Okay.
Thank you, sir.
Even epigastric distress, vomiting, sweating, these are also attributed to heart problems.
So majorly, it is also to do with the fact that in a lay person, acidity is kind of taken as a symptom which actually could be the onset of a major heart attack.
Yeah.
Very, very
Mr. Dinyar Patel,
sir,
if I can add to that,
sir.
Dr. Kumra stressed upon it, you are also trying to say, but acidity is exactly what looks like gas. I will just give you a concrete example. One of our father of cardiology, his name is Dr. Williams. He in his book starts his first chapter, how the case presents. And in his lifetime has taken 3,000 lectures addressing lay people and educating them that whenever you feel gas-like feeling, you should always suspect that there can be coronary artery disease. Now, one fine day, he comes home from his office and he tells his wife, I have a gas. Prepare a strong soda for me. He takes a soda, goes around. He says the soda was not strong enough. Prepare a double strong soda. Goes around again, 10 minutes walk. Then suddenly he clicks. 3,000 times I have told people, if it is gas, it can be cardiac. And now he realizes that this is cardiac. He takes an ECG and infarct. So even in a person who has been educating people left, right, and corner, he misses that. And so many times we see a patient in a clinic, when you tell him that it is not a gas, he's not willing to accept it. Then I have a trick over there. I tell him there are two types of gas. One gas arising from the heart and one from the stomach. This is from the heart. And then he accepts it.
Interesting answer, sir. Dr. Shah, continue to stay. We got a question for you, sir. What are the prominent biochemical and cardiac biomarkers which are significant in evaluation and management of suspected ACS?
Right. So whenever there is a case where we are suspecting acute coronary syndrome, that means a presentation because of less blood circulation to the muscles of the heart. The most important biochemical marker which is used nowadays is what is known as troponin. Or also nowadays we have a sensitive way of doing it, it is known as high sensitive troponin. This is the most important marker as on today to diagnose this. Only question which we have to remember is it takes some time for the marker to rise from the onset of pain. So if you do the test pretty early, immediately after chest pain, maybe your marker may be normal, and therefore you can't just by doing one test done within first 1 hour or 2 hours, be doubly sure that even if it is normal, you can still have a patient with it. So what we do is, there is something known as, you do 2 sequential tests. One, as soon as you see the patient, high sensitive troponin, and repeat one more at the end of 2 hours. If you find the first itself is grossly abnormal, it confirms. But if not, you do the second test, and if you see a rising titer, the difference between the first and the second test is significantly more, meaning that by rising titer, it proves a diagnosis of acute coronary syndrome. And this is what is known as rule in. That means diagnosis on 2 sequential troponin tests done at a space of 2 to 3 hours, and a rising titer would tell you that it is so. So this is the most important marker. And if a patient has troponin positive, this patient do not do well on long-term and short-term both. And they need very aggressive initial hospitalization, treatment, and investigations like angiography and even maybe interventions after that. So the most important marker is high sensitive troponin test done initially and if necessary at a period of 2 to 3 hours, and a rising titer would be most important in that situation. This test is done from various labs, and there are specific readings and for that. So probably you'll have to go based on the individual lab. But essential criteria is rising high sensitivity troponin test.
Very, very valid, sir. Very valid. Thank you so much, Dr. Shah, for your very valuable point of view. Dr. Kahale, sir, I come to you. So my question to you is, what is the significance and risk factors of pre-treatment in the management of ACS?
So here what we are trying to understand,
yes, sir,
that how you give pre-treatment. Pre-treatment means before a patient is admitted, that is what the word pre-treatment means, or a patient undergoes angiography or any type of procedure. So pre-treatment is very important. The role of pre-treatment in acute coronary syndrome is to prevent the progression of coronary thrombosis. Now, what we understand, acute coronary syndrome or an acute heart attack, though there are blockages in the heart artery, there is a superimposed thrombus, and there how is the role of what we call is anti-thrombotic drugs. So you have 2 types of anti-thrombotic drugs. One we call our anti-platelet agent, and another are anticoagulants. So both anti-platelet agent and anticoagulant giving upfront before taking these patients for angiography reduces the size of heart attack, chances of heart attack, and that saves lives of the patient. So upstream or pre-treatment with antiplatelet agent. So what are the antiplatelet agent? The first recommended antiplatelet agent is aspirin. The aspirin 300 milligram chewable is one of the first drug which is given for the pre-treatment. Second thing is, and this pre-treatment even can be given at home when there is a high suspicion. People do carry the tablets of clopidogrel and aspirin. A few of them who are aware or educated, or they already have suffered acute coronary syndrome themselves or them in family. So another tablet is use of clopidogrel or oblique ticagrelor. So these are the 2 drugs which are given in addition to aspirin. Either of them, what we call is antiplatelet agent, and anticoagulant usually are the injectable anticoagulant. A general practitioner can give something called as a low molecular heparin or a heparin, and they can send to the higher center, because acute coronary syndrome would require a intensive cardiac care unit. And if this pre-treatment is not received at home, at a general practitioner place, patient is coming to the hospital, then this is given in the emergency before any admission, before any paperwork is done. And that is to protect the further clotting inside the heart arteries, and to prevent the, as I have told, the size of heart attack and reducing the chances of death.
Fair enough, sir. Very, very, very well point of view. Thank you. Thank you so much, Doctor. Dr. Shah, we come back to you, sir, with our question. Based on the patient risk, how to choose P2Y12 receptor inhibitors?
Right. So primarily, now when we're talking of this, I would like to introduce a concept of what is known as bleeding risk and ischemic risk. Essentially, we are dealing with a disease where there is obstruction in the flow of the muscles of the heart because of the blockages of the vessel, because of clot, thrombus, and platelets, and etc. The goal of therapy is to re-establish blood circulation as early as possible and as best as possible. And this is done with the help of anticoagulant and antiplatelet drugs. Now, when we are talking of antiplatelet drugs, the benefit is that it will re-establish the flow. The disadvantage is all these drugs can overact sometimes and cause bleeding in various sites of the body. So the benefit, improvement in blood circulation, the disadvantage, bleeding tendency. And whenever you want to give a drug, you will have to balance the bleeding risk and the ischemic risk. And based on that, you will decide which antiplatelet to give. There are some antiplatelet drugs which are not very powerful, so they will not reduce ischemia to that level, but also will not put too much of bleeding. There are some drugs, antiplatelet drugs like Prasugrel or Ticagrelor, which are powerful, a very powerful anti-ischemic agent, but they can also cause bleeding. And remember that bleeding is a biggest nightmare for cardiologists. If you give a drug and if a patient bleeds, we land up into a lot of problems. Let us understand why. When the bleeding occurs, you are so many times forced to give the vital drugs like antiplatelet drugs. You are forced to stop the drugs like anticoagulants. If the bleeding is more, you are even forced to stop ancillary additional drugs like beta blockers and ACE inhibitors. Sometimes there might be hypotension, you'll be forced to give drugs like noradrenaline drips. You might be forced to give blood transfusions, and collectively all these things put together increases the risk of death by 5 to 15 times compared to a person who has not bled. Meaning thereby, you will have to every time be sure that you give a drug to a person where it does not cause bleeding. And therefore, it is equally imperative to know what is the bleeding risk. There are various formulas to find out the bleeding risk. The common clinical parameters are elderly patient, females, weight less than 60 kg, patient with kidney failure, patient with past history of bleeding. All these patients have a high chances of bleeding. And if you have this type of patient, where you have to give a drug, you will give drug like clopidogrel as an antiplatelet P2Y12. As opposed to that, if the patient does not have high bleeding risk, but has a high ischemic risk, like for example, is a young patient, multiple problems, multiple stents have been put, where the chances of reblockages are very high, you will give powerful drugs like Prasugrel or Ticagrelor, which are the two P2Y12 inhibitors. That means patient with low bleeding risk, clopidogrel, patient with high bleeding risk, patient with high bleeding risk, clopidogrel, and patient with high ischemic risk, it is Prasugrel or Ticagrelor. Another important point which I will have to remember over here is, by and large, the pre-treatment was aspirin, clopidogrel, and we used to say what Dr. Kahale said, Ticagrelor, etc. But now in the latest guidelines, they have found that even in pre-treatment, if you are planning to do an intervention in that patient, that means you are planning an angiography in that patient, it may not be worthwhile giving Ticagrelor or Prasugrel unless you have done an angiogram and seen the coronary anatomy. And there also we have further data to show that after angiography, based on a very important registry known as SCAR registry involving 65,000 patients, it has been clearly documented that Prasugrel is slightly superior to Ticagrelor. There's also another important trial known as ISA-REACT trial where there was head-to-head comparison with these two drugs. So in that situation, probably the patient who is undergoing intervention, you would like to give this drug only after angiography and preferably Prasugrel. The reason again has been very clearly explained that it has an anti-inflammatory action, anti-endothelial action, and because of all these things, Prasugrel so many times scores over this. And this is what is exactly ESC 2020 guidelines tell you. So in short, if I have to summarize in 3-4 sentences, if a patient has high bleeding risk, clopidogrel. If the patient has low bleeding risk and high ischemic risk, than ticagrelor or this. If you're doing intervention, do an angio and then only give this drug, and prasugrel before doing that. Thank you.
That means, sir, as we stand, the case history of the patient is very important
Absolutely.
before administering any of these drugs. I think that's a very, very valid statement once again. Thank you, sir. We come back to Dr. Dayanand. Sir, a question for you. Sir, what are the several coronary risk factors that influence the initiation of arthrocyclorosis?
Yeah, atherosclerosis, that's right. See, aging is one of the risk factors where people develop atherosclerosis. But nowadays we find in India, the younger population at the ages of 40, 45 do have atherosclerotic heart disease. And many of them have even calcium burden high in their coronaries, or they have calcified coronary arteries. So what are other risk factors? Common as being high blood pressure. Those who have persistently high blood pressure, their risk of atherosclerosis goes up. That is very common because high blood pressure generally lands up with endothelial dysfunction. Once you develop endothelial dysfunction, the atherosclerosis goes on increasing in these particular group of patients. Now in a city like India and Mumbai or any of the metropolitan cities, we have found that even younger where people do suffer from diabetes and blood pressure, so they have a high risk of atherosclerotic coronary artery disease. High cholesterol, now this lipids have to be controlled, have to be kept under control, like high cholesterol or high LDL cholesterol, low HDL and high triglycerides. See, Indians suffer from coronary artery disease because of dyslipidemia. Indians do suffer from a triad called high cholesterol, high LDL cholesterol, low HDL, and high triglycerides. All these three deadly triad of lipids do affect our coronaries and they land up with atherosclerotic heart disease. Even high levels of C-reactive protein. There is a study where they have conducted, they found person having very high levels of C-reactive protein, they land up with atherosclerosis. So there was a trial called Jupiter trial where they gave patients rosuvastatin, and then when they saw that the incidence of coronary artery disease was definitely less in those patients who had high hsCRP, and with rosuvastatin the incidence came down. And patients who are diabetic, diabetes itself is a severe, diabetes is one particular condition where it affects right from head to toe. Your eyes get affected, brain gets affected, heart gets affected, all your circulatory system gets affected. There you have a lot of endothelial dysfunction which occurs in these patients and they develop atherosclerosis. So diabetes has to be kept under control. One of the markers being HbA1c. Everybody harps on HbA1c. So one has to see that the HbA1c levels are under control. Nowadays we have got a lot of newer drugs for diabetes, which definitely protects the heart, protects the circulatory system, and the incidence of coronary artery disease may come down. Then we have obesity. Now everybody has to see that ideal body weight has to be maintained. Obesity is the crux of all the problems like hypertension, diabetes, coronary artery disease. So obesity has to be controlled. You have to harp on it that the person exercises properly, has a normal good diet, and has a diet which will not cause any obesity. So that is another common thing. And the other major thing is the sleep apnea. Sleep apnea is one condition where person snores during sleep and suddenly gets up in the middle of night and he pants for breath. So in these people, if you give them those BiPAP machines for sleeping, they are benefited. So sleep apnea is one of the major conditions where people suffer from diabetes, hypertension, and ischemic heart disease. If sleep apnea is corrected, when your weight is brought under control, your diabetes is controlled, your risk of ischemic heart disease definitely goes down. Smoking and tobacco chewing, which I told you, this is the killer for all of our patients. So one has to see that the bad habit like smoking and tobacco should be out of the Indian society. And lastly, we have a family history of early coronary artery disease. If somebody's parents who suffered from coronary artery disease at a very young age, then their children, they have to be very particular that they have to really lead a normal, good lifestyle, no sedentary habits, and do proper exercise and diet. So at least whatever is there in our hands, we can prevent coronary artery disease attacking us. Otherwise, whatever genetically it is written, I don't think we can change it. Okay. Thank you.
So Dr. Kumla, just to add to what you said, that on a lighter vein, of course,
Yeah.
that a heart is a rich man's disease, as we have, because
Exactly,
the fact is the ones who exercise, the ones who eat a diet that is close to nature, possibly are less prone than the ones who live in an AC and lead a very sedate life.
Many years ago, no, many of the lectures I say, 50 years ago, people in India died of undernutrition. Now people die of overnutrition.
Very valid point, sir. I think that's the crux of all of it. Thank you so much, sir. Very well put. Coming to Dr. Kahale now, so question to you. Is prasugrel becoming the preferred P2Y12 inhibitor? What are the evolving treatments in the management of ACS, sir?
So as this topic has already been covered well by Dr. Bhaskar Shah, telling that when you add another antiplatelet, so you have to give double antiplatelet for patient with acute coronary syndrome. So one is aspirin. We are going nowadays for lower doses of aspirin, and another agent is either an ticagrelor or prasugrel if the patient is undergoing any angioplasty. Clopidogrel is little weaker one. Now there is a competition where which to choose. So usually all these patients are high risk, and definitely ticagrelor and prasugrel are the preferred choice. Here again the balance is between the bleeding risk and the ischemic risk. Means what is the chance of clotting inside the heart arteries and what is the chance of bleeding from other point. Because when you are giving a drug to a patient, it will work in whole of the body. It's not only working in the heart artery. You can bleed in the brain, you can bleed in the gut. So if your bleeding risk is high, then clopidogrel is the preferred. And now till now last 10 years we had an addition data just telling that ticagrelor is better, because prasugrel had an high bleeding risk, but has newer data like SCAR registry and the other data which Dr. Bhaskar Shah has told, prasugrel is now coming up. But yes, what I can say, though it is coming up, data is promising, but as far as practice is concerned, ticagrelor we are using still almost a decade, and prasugrel users has been very less. So probably there are no problems with ticagrelor, though the data shows. So the prasugrel though is a promising, but to enter in the practice there is a barrier because there are no major problem with the existing drug which is ticagrelor.
Just a layman's perspective, just 1 second to understand your point of view. We are talking about bleeding as in both internal and external. It's not only external in a situation where exactly,
because you
that is
blood thinner to a patient with acute coronary syndrome.
Agreed.
So you bleed. So
right.
There was a competition between prasugrel and ticagrelor where
Perfect.
Both are reducing clotting, but
right.
ticagrelor was less bleeding and prasugrel was more.
Right.
But
right.
now as the new data comes, as the science evolves, we get more
right.
larger registries and trials.
Right.
Now it is that probably prasugrel is also a good molecule because it is not showing that bleeding risk in current scenario.
Okay.
We are using it. But though prasugrel, so your question is prasugrel coming up? Data says prasugrel is coming up.
Right.
But we see practice when I am writing, I am not writing despite this data because there is no major problem with the existing ticagrelor which we are using since more than 10 years. Ticagrelor is superior to older clopidogrel, and what we say is good competitor to upcoming prasugrel. Though prasugrel is a very old drug, but because of not good data, it is gone down in the prescription. And as your question says, it's though coming up as far as data is concerned, but in our clinical practice, still ticagrelor has a major chunk.
Fair enough, sir. Thank you. Thank you so much. Dr. Shah, coming to you. Sir, what are the prominent ACC/AHA recommended guidelines for initiation of anticoagulant therapy?
Right. Now, when you're talking of anticoagulant therapy for an acute coronary syndrome, the details have been there from time immemorial. right from early days where we used to use what we say unfractionated heparin, followed by daters with low molecular heparin, followed by Fonda Paranox, and now some daters on newer oral anticoagulants. We all know that in a patient of acute coronary syndrome, whether they are managed conservatively without any angiography or interventions like angioplasty, or whether invasively with angiography and angioplasty, heparin forms one of the major backbone of the therapy. And in heparin, initially we had unfractionated heparin, where the action was unpredictable because of its plasma protein binding. And it used to bind to what is known as plasma factor 4, and therefore there were thrombocytopenia is one of the major problems. However, it was short acting, it is very cheap, and therefore even in today in interventions, we still use heparin, unfractionated heparin in a dose of 60-70 milligram per kg bolus, followed by 50 to 70 units or 100 units at the most per hour per kg body weight later on. Very commonly used in interventions, especially angiography, followed by angioplasties. However, when you're managing a patient conservatively with drug therapy and you are not planning to do an intervention, the treatment of choice is low molecular heparin, which is a part or fraction of that unfractionated heparin, where most of the problems are eliminated. It has less protein binding and therefore very predictable action, and you don't need to do testing like APTT or ACT to find out the effect of the drug. Plus, it does not bind too much to plasma factor 4 and does not cause thrombocytopenia. So low molecular heparin is again a very important drug, cornerstone in every single patient of acute coronary syndrome. Then came a drug known as Fonda Paranox, which was still a much better derivative of this, which again works well given in the single dose, much lesser bleeding tendency compared to unfractionated heparin and even to low molecular heparin. So you've got all these three drugs which have been used. There have been molecules known as bivaleuridine, which is another anticoagulant which was used during acute intervention, which is again supposed to be a very useful drug. There are data for all of them, multiple trials trying to prove. But by and large, as on today, it is low molecular heparin. In most of the cases, in intervention, it is unfractionated heparin and or Fonda Paranox. The only limitation of Fonda Paranox is that whenever you use Fonda Paranox and a patient undergoes intervention, you can get thrombus in the catheter, which can be prevented by giving a bolus of unfractionated heparin. And now, lastly, newer oral anticoagulants have been also tried along with other drugs in this patient of acute coronary syndrome. And there was a very classical trial with a low dose rivaroxaban given in the dose of 2.5 milligram twice a day, known as Atlas ACS TB51 trial, where it showed benefit over dual antiplatelet drug. So now there are people who have a high ischemic risk, and when you do long-term therapy, along with antiplatelet drug, there are reports of Atlas ACS trial trying to give you this drug. So now anticoagulant also is there. So in short, it is one of the major backbone therapy. Low molecular heparin is the commonest of the lot, unfractionated procedures, behavioral in procedures. And nowadays, patients where you can't give powerful drugs like Teco or anything, you can use newer oral anticoagulant. Though newer oral anticoagulant with other drugs like rivaroxaban and apixaban showed utter failure and did not work well. It's only rivaroxaban in the dose of 2.5 milligram BID. Thank you.
Thank you. Thank you, Dr. Shah. Dr. Dayanand, back to you, sir. So what is the role of inflammation and thrombosis in ACS?
About inflammation and thrombosis, we do see patients with coronary artery disease having inflammation and thrombosis. Right from, we can come from the pneumococcal bacteria giving rise to coronary artery disease because of infection and inflammation. So similarly, there's something called as Kawasaki disease, which is also one of the infective etiology which gave rise to coronary artery disease in the young infants. Then we have this Roxas trial many years ago, roxithromycin was used for 6 weeks in patients with coronary artery disease, where they found postmortem studies showed certain bacteria which were grown up in those patients who died of acute coronary syndrome. So roxithromycin was used for 6 weeks. So this was about the infection giving rise to inflammation. Then about inflammation per se, today in the pandemic of corona, COVID, there are certain patients who suddenly develop thrombosis and they do succumb to this following a massive heart attack. And this thrombosis is secondary to COVID infection itself. So where there's a lot of inflammatory state, there's thrombosis in these patients, and those who come to the cath labs, many of them may have only thrombosis all over in their arteries. You remove the thrombus, they may have a clean coronaries, and they come out very successful after the thrombosis sucked out. That is with the infection following the COVID-19 infection. Then diabetes itself is an inflammatory disease per se, where somebody having an atherosclerotic plaque, this plaque ruptures. Once they rupture because of this inflammation or infection, when they rupture, they attract a lot of these platelets and other coagulant materials, and then that forms a thrombus and a fibrin formation. So that gives rise to the inflammatory response, giving rise to acute coronary artery disease. So these are the various things where you have inflammation giving rise to coronary artery disease. So today, even in this corona period, there are people who have many of them have several strokes as well. And stroke patients can have inflammation in their cerebral arteries, giving rise to a massive hemiplegia.
Are we saying that the after effects of corona, or while they are suffering from?
Yeah, after effects of corona as well as corona infection itself, there's a lot of thrombotic state in these particular patients.
Interesting. Very valid point, sir. Thank you. Thank you, doctor.
Yeah.
Just to add to that,
Sir.
What Dr. Kumla said is very strong point that inflammation, and then there are now trials and there are enough evidence to show that anti-inflammatory drugs, a drug known as allopurinol, given in the dose of 0.5 milligram twice a day, are known to reduce the incidence of acute coronary syndrome. So in a patient with a known coronary artery disease, if you give them anti-inflammatory drug like allopurinol in the dose of 0.5 milligram twice a day, it is a useful adjuvant to prevent inflammation and thereby prevent acute coronary syndrome.
And colchicine has been tried. Well, Bhaskar, colchicine as well.
Thanks, sir. Thank you. Dr. Kahale, sir, question for you, sir. Amongst the recommended 4 anticoagulant agents, unfractional heparin, enoxaparin, fondaparin, and bivalirudin, depending on patient risk, how to initiate an effective therapy. My pronunciation is bad. I am apologizing once again.
So basically, these are all 4 anticoagulant, and I think Dr. Bhaskar Shah has explained how a heparin and low molecular heparin is, improving. Now, these are the anticoagulants, and as we have started a presentation that you require antiplatelet and anticoagulant, and we are getting now stronger and stronger antiplatelet agents. We are getting better stents, and our angioplasty gadgets are improving. So if we are doing an intervention, which means an angioplasty, then what we do is we use heparin as an anticoagulant during the angioplasty, because heparin will not allow our blood to clot on the catheter, wire, stents which we are using. And here we are giving aspirin and ticagrelor. So heparin is the king, and it will and it is dominated as an anticoagulant over more than 50 to 60 years. Though low molecular heparin came in a practice, and it has advantages that it is more reliable biologically, because heparin is unpredictable. You need to monitor the heparin with the various tests that it is not anticoagulant in less or more, and it is within the range, and then you adjust the dose of heparin. So low molecular heparin you don't need to monitor. You can give 1 injection. Heparin which goes away within half an hour to 2 hours. It the low molecular heparin remains in the circulation for 12 hours. So you have to give it only twice a day, in contrast to continuous IV infusion heparin if you want an anticoagulation. So when we doing intervention or an angioplasty, we use heparin, give antiplatelet and heparin, because we just want to cover the procedure, which is 1 hour angioplasty. Nowadays, angioplasty timings are coming down, and even in 30 minutes, many a time we do 15 to 30 minutes, we finish the angioplasty. So we give a heparin. Low molecular heparin, if you are medically treating, or you think that patient has too much of clot that beyond aspirin and ticagrelor patient will require heparin, then twice a day low molecular heparin can be continued for 3 to 5 days, but that is going on, going low, use of low molecular heparin, because we just want an anticoagulant during an angioplasty. Definitely, if patient is not a candidate for angioplasty, is for only medicine, then we can give either a low molecular heparin once a day, what you call is Fonda Paranox. Now, the third drug, Fonda Paranox, is usually reserved only because, for medically managed patient, because it is long acting once a day. The only clinical situation Fonda Paranox is useful is heparin-induced thrombocytopenia. If heparin is causing clumping of platelets, a condition called heparin-induced thrombocytopenia, there Aristra we are sometime using, or we are using the fourth drug, which is bivalirudin. Again, Fonda Paranox has less bleeding and it is once a day. But when we speak of angioplasty, we have to give again additional heparin if patient is given an anticoagulant, which is Fonda Paranox. So use of Fonda Paranox is minimal for medically treated patient, once a day drug. It is more little convenient than low molecular heparin. Now, as far as bivalirudin, again is a short acting drug. It is an infusion which is given, and it is only during the angioplasty for 1.5 hours. Unless we are not comfortable with heparin, it is not given, because it is 10 to 15 times more costlier than heparin. And as we are telling that our angioplasty is improved, where anti-platelet agents are improved, our procedure timing are reduced, and even newer catheters, they have very good coatings which doesn't allow blood to clot so easily. So considering all these factors, during an angioplasty, the dominant molecule is unfractionated heparin. Then when you are medical treatment, we use either enoxaparin or Fonda Paranox. Bivalirudin is rarest when we have problem with heparin during the angioplasty. And one more point to add, that the enoxaparin is not to be used when you have heparin-induced thrombocytopenia.
Thank you.
Another point I would like to add, please check the renal status of many of the patients. If they're elderly, then those of all these drugs may have to be reduced. Yes, Praveen, am I right?
Yeah,
Absolutely.
so we have one more question related to, how you are, maybe I can take right now. What are the difference between heparin and low molecular heparin? And few points we have already taken. And
Yeah,
one
correct.
additional which Dr. Kumbla has brought out, that heparin is degraded in the body. Low molecular heparin has a renal excretion, which means it will go throughout by the kidney. And many of our diabetic patients, they have kidney issues. And if you give them the routine diseases, they may bleed. They may bleed more. So it is very careful. So patients with kidney disease, heparin becomes safest drug, because it is destroyed within the body within half an hour. We can give infusion, we can titrate. Because finally, though we want to reduce clotting, we don't want excess bleeding, and we want to balance that. So when there is a kidney dysfunction, low molecular heparin has to be in the reduced doses. Second thing is, sometime in accident and emergency, or a general practitioner has given an low molecular heparin, and I am taking this patient for an angioplasty. If it is within 8 hours, I may not give additional heparin. If it is 8 to 12 hours, then I would give a little lower dose, and after 12 hours, we have to give full dose of heparin.
So our Facebook and our live is now being accessed by a number of people, because we're getting audience questions. Even non-medical people are there, like me. Interesting. I'll take an audience question, sir, if it's okay with you. Any of your doctors can answer it.
Yeah.
Thank you. Question: how to differentiate pain acidity due to acidity from cardiac pain? I think we have spoken about this, but maybe somebody specifically asked this question. So if one can just maybe spend about a couple of
I will try to take this.
That'll be very kind, sir.
Primarily, when you are talking of abdominal discomfort or gaseous feeling or acidity, the key point to remember is, whenever you walk, the gas related to stomach tend to become less. But if that's acidity or gaseous feeling is secondary to cardiac problem, as you start walking, the discomfort will become more and more and will force the patient to stop walking. So if the discomfort increases while walking, the gaseous feeling, it is cardiac. If it disappears while walking, it is probably gastric.
Very nice, Bhaskar. Another point is that many of patients come with epigastric pain, right hypochondriac pain, they'll end up in ICUs. And an ultrasound done picks up gallstone, acute cholecystitis. So this also mimics like a cardiac pain, and people end
Very
up
common, very common.
Yeah, very common.
So the old adage that if you have a left hand pain, it's associated with a heart attack. Does that hold true, sir, in today's day and age?
Again, the important thing which you have to remember is it is not only the presence or absence of pain which is important, but its relation to exertion is extremely important. Relation to posture is important. Relation to movement of arm is important. For example, I have a shoulder pain. If I move it up and the pain worsens, it is not cardiac. The shoulder pain related to heart will not improve, neither worsen on movement of arm. Number two, if the same pain, when I walk, if it worsens, and when I stop, it disappears, it is cardiac. So there is a definite relation to walk. If the pain anywhere, any pain right from jaw, chest, arm, back, abdomen, if it worsens on walking and disappears or decreases on stopping the walk, it is cardiac. That is what is important. And last is often relation to posture. Most of these cardiac patients, the discomfort will become much better when you sit up compared to lying down. The moment they lie down, the pain discomfort worsens. They sit up, it becomes better. And that is a paradox. Normally, when someone suspects a cardiac pain, as a layman, everyone wants, don't take rest, they force him to lie down. And he's uncomfortable, he wants to sit up, and you force him to lie down. It's the other way around. Actually, the most comfortable position for cardiac patient is sitting position.
Ah, interesting.
So if you have a pain which is better in sitting position, or it worsens on walking, then it is cardiac. If the pain is same lying, sitting, if it worsens on movement of arm and does not get altered on walking, it is non-cardiac.
Another point I would say about post-lunch chest pains. After meals, elderly patients do complain of chest discomfort and epigastric discomfort.
So
And
chest pain, sir, we are not talking left or right. Chest,
chest pain or epigastric, no, upper abdomen pain. After lunch, if when he walks, if he gets pain, it is more related to heart. Now, what is the physiology behind this? In normal patients, after lunch or dinner, the blood is diverted to the stomach, okay, alimentary system, and less to the heart. One who is having obstructive coronary obstructions, there the blood flow is definitely going to go down, and so he'll experience pain. Whereas a normal person, when the blood flow decreases, he doesn't experience pain because he doesn't have any obstruction. So this is very commonly mistaken, and people do still say that elderly patients after a lunch or dinner, please walk 100 steps. That is wrong. Okay. So elderly
Very
people who are having, yes.
Very typically, the book picture is that they show an elderly male. It goes to a hotel. He has eaten food. It is cold. He wears a coat, and immediately after food, he walks out of the hotel and walks. And within 10-20 steps, he finds there is a difficulty. This is very typical picture. On walking in winter after food. And another important thing, so many times, which helps us to differentiate is, if you get the discomfort in the epigastrium or the abdomen, immediately after food, within first 15-20 minutes, it is more likely to be cardiac. If you get it after 1.5 to 2 hours, it is more likely to be gases.
Very, very valid. Very valid. Sir, non-medical person is also learning medical terminology, and I'm so happy that there's so much to learn from some people like you. Dr. Shah, sir, question for you. Is unfractional heparin associated with low death rate or MI? What are the prominent monitoring parameters of UFH therapy?
Basically, as we already have exemplified, we have told this thing just to repeat and make it clear. Unfractionated heparin is the first heparin which came in market. It is a much more longer molecule. It binds to proteins and therefore unpredictable action. And therefore, whenever you want to give this, you have to monitor and adjust the dose of the drug. The monitoring is done by a test known as ACT or APTT. So these are the tests which are done, and you try and maintain ACT somewhere in the range of 250 to 300, or APTTT 1.5 to 2.5 times more. We are also worried that this patient can get thrombocytopenia every second or third day. You need to get your platelet count up. So that is how we are going to monitor the therapy of unfractionated heparin. But if you want to give it for a longer time, this monitoring is all cumbersome and still unpredictable. You can end up with bleeding, and therefore the treatment is most of the time switched toward to low molecular heparin or Fonda Paranox, where all this monitoring is not mandatory.
So we have another 5 minutes to go for the session. So I'd like to use this to ask one general question also, which may not be very, very medically appropriate, but all the same. If you start on any of these heart beta blockers or whatever, statins, whatever, is it important that it needs to be continued for life? Once you start, you cannot taper it down. Is there any medical theory around that? Because, well, because I, for one, have that niggling issue. Then what do you do?
Okay, we'll just try and answer that. See, now the basic disease in this patient where we have started beta blockers, ACE inhibitors, and lipid therapy is that you have a tendency of deposition of fat and cholesterol in the blood vessel and form disease, what is known as atherosclerotic plaque. This plaque grow with increasing level of cholesterol and various other things, or various risk factors which Dr. Coagulant enumerated in the past. And the plaque at some point of time may rupture because of inflammation and give rise to a total blockage of the vessel. When you give a drug, you just can remove, there are two parts to this. There is a hard block and there is a soft block. The soft block can dissolve, but the hard block and the plaque will remain permanently there. These drugs, they modify the character of this plaque in such a way that it no more ruptures and no more causes full blockage of the vessel. But the action is as long as you are taking the drugs on. The moment you stop the drug, the chances of the plaque reverting back to its original characteristic where it can rupture can happen. And therefore, most of these patients will invariably need anti-platelet drug, that is blood thinners, and cholesterol reducing drug known as lipids for a long time and practically lifelong.
Side effects, sir? Side effects?
Linear, one sentence I could like to add.
Sir.
I tell all my patients,
Sir.
you have to take this drug lifelong for long life. What do you want?
But are there any side effects? This is the larger question a layman asks.
No.
So I'm on.
Most of these drugs, before they come in market, they've been amply tried in large trials and controlled patients and found out to see whether the side effects are acceptable vis-a-vis the benefits which we are getting. The benefits are quite out of proportion to the occasional disadvantage which the drug may have. We are always called for follow-up, and in case we find that you are getting into some problems, we can always modify the drugs and maybe change over to the different molecule.
Yeah, true.
But by and large, they are very safe. For example, lipids or statins, they are drugs which once upon a time in literature were known as tap water drug. That means they are as safe as tap water.
That explains it all.
I always end up with like what Dr. Coagulant said, long life,
lifelong for long life.
And more important, I ask, sir, whether I get addicted to it. And I say, I want you to get addicted to it. If you don't get addicted, I'm worried about it. And I always tell them your early morning prayer should always include one sentence. Oh God, let me get addicted to the drug for a very long life.
And anyway, with these drugs on, I think regular follow-up is also very important. Certain people take the drugs, some, as Bhaskar said, beta blocker, fine. They may land up to you after 1 year, when sometimes their heart rates must have dropped down to the extent of complete heart block. That is very important. Follow-up is also very important.
Sir, I've also seen this.
Because whenever we are giving any prolonged therapy, follow-up is a must. You can't just go on taking drugs without close follow-up. And we are all aware, we have been using these molecules for now donkey's years, 20, 30, 40 years. We know where it creates problem, how to pick up this problem, how to take care of the problem. So I'm sure if you just remain in touch base with your cardiologist, and really take the drug meticulously, I can say that by and large, most of the cardiac patients, if treated properly, adequately followed up, can have practically the same life with a person who does not have the disease. You have tremendous advances, and all those advances, if the benefits are passed on to the patient in an appropriate manner, they can really lead a very, very long, cherished life.
Great. So, in the interest of time, we would like to take this opportunity to say that I think it was a learning experience for a layman like me, a person who is non-medical, but there's so much to learn, so much to understand. Also, we learned today that lifestyle is a major cause, and if we keep our diet restricted, if we are able to see our doctor at appropriate timings in our in the sequence of a year, I think heart diseases themselves can be prevented. Also, myths surrounding medication, which is that can it be continued lifelong, etc. These I think were also busted here. Certain drugs we spoke about, we also spoke about how best we can contain issues, and I think that for us was the greatest learning. So while I thank you for joining us today, Dr. Praveen, Dr. Bhaskar, Dr. Dayanand, thank you for joining TOI and Biological E on this webinar on anticoagulation in acute coronary syndrome. We hope to have many more such enriching discussions in future with you. And it was so kind to give us your very, very important time. Thank you once again, doctors. Hope you had a wonderful time just like I did.
It was, on our side, it was a great pleasure to be part of it. And if it is going to benefit someone, we'll be really, very happy to see.
It has benefited me if nobody else, sir. That's what I can say.
Thank you very much.
Sir, thank you all. Thank you very much.
Last sentence is prevention is better than intervention. Prevention is better than cure. Prevention is better than intervention.
Actually, I mean, if you were to say, just to add to that, India is a poor country, and the only thing which we can afford across the country is prevention. Once you get the disease, it is very costly. So many cannot afford. And therefore, try best to prevent the disease rather than to get in trying to.
Very true. So thanks for joining Dr. Praveen from Kokilaben, Dhirubhai Ambani Hospital, Dr. Bhaskar Shah, Dr. Dayanand Kumble once again. Sir, thank you and all the very best.
Thank you, sir.
Thank you.